Yes, good evening all. I hope the audio and video is fine. Welcome to DBMCI eGurukul and myself, Dr. Bharath Kumar, the Pharmaceutical Faculty, DBMCI eGurukul. So welcome to the doubt solving session, Pharmacology. So we had asked you to check for the doubts, and then accordingly we'll be taking that queries and solving that. So let me see your queries. So how many of you are live now? Okay, I think it has started. Yeah. So some of the queries which we already have received, and I'll be answering them. And in between, if you have any queries, you can ask me. So the first query is, sir, can you please tell nasal decongestants are alpha 1 or alpha 2 agonist? So remember, the nasal decongestants, what we use, nasal decongestants, the topical ones what we use, they are called oxymetazoline, xylometazoline. So they are mainly alpha 2 agonist. They are mainly alpha 2 agonist more than alpha 1 agonist. Both are present, but mainly they are alpha 2. Do you remember that alpha 2 is present in two locations? Alpha 2 is mainly located in presynaptic. Major location is in presynaptic. That is here. If this is synapse, this is the location of alpha 2. This is a postsynapse. So that is the major location of alpha 2. But in certain places, it is also postsynaptic. So we have postsynaptic alpha 2. And the thing is, in blood vessel, it is alpha 2 postsynaptic, which will cause vasoconstriction. And that's why we use it as nasal decongestant. So oxymetazoline, xylometazoline, they are mainly acting on alpha 2 rather than alpha 1. Right? So this is the postsynaptic alpha 2 action which is responsible for their action as nasal decongestant. Suppose there is a question on an oral nasal decongestant. Oral nasal decongestant, they are mainly phenylephrine. They are given oral. And one more is pseudoephedrine. So their major action is on alpha 1. Their major action is on alpha 1 agonism. Right? Yes, that doubt is cleared. Let me check any other queries from your side. Okay. So Akhilesh Chandran, that's the in detail. So alpha 2, they are mainly alpha 2 agonist and also alpha 1 agonist. If both are given the option, I will choose alpha 2 as the answer. Yes. Now, coming on to the next question. Sir, all the antiplatelet drugs have ADR bleeding, then why particularly prasugrel is counted against stroke due to bleeding? Now, for stroke, only 3 antiplatelet drugs are approved for stroke prophylaxis. So when you give stroke prophylaxis secondary after an ischemic stroke or after a TIA, we want to give an antiplatelet therapy. And there are 3 drugs: aspirin, clopidogrel, along with one more drug called dipyridamole. These are the 3 antiplatelet drugs which are used for stroke prophylaxis. Initial days after a stroke, we use a dual antiplatelet therapy. After that, we will use a single therapy. Any antiplatelet drug, the major risk is bleeding. So there is always a risk. And in that, the better ones are this one with lower risk. But other drugs, apart from this, the prasugrel, the cangrel, ticagrelor, their risk of bleeding is more. So that's why, as per the studies, these are the 3 drugs we use for stroke prophylaxis. Apart from that, all the other antiplatelet drugs, remember this very important point, all the other antiplatelet drugs, they are GP2B3 antagonist, they are P2Y12 antagonist, then ADP, that is PR antagonist, aspirin, all of them can be used for MI, except one, all the antiplatelets for MI prophylaxis, except one. What is that? What is that which is not used in MI prophylaxis? Anybody? The drug which is not used in MI prophylaxis is dipyridamole. Now, can you tell me why dipyridamole is not used in MI prophylaxis or not in a patient with angina pectoris? Anybody? So one more drug which is not used is cilostazol. Cilostazol is used only in peripheral vascular disease. It is not for MI prophylaxis. Yes, can you tell me why dipyridamole is not used for this? Anyone? Because guys, dipyridamole causes coronary steal phenomenon. The meaning is it will dilate the non-ischemic zone where the blood is not required and steal the blood from ischemic zone, and that's why we don't use it for MI prophylaxis, because of the coronary steal phenomenon. Yes, so let us see the other questions. Sir, in pharmacotherapy of glaucoma, you told that beta-2 receptor are present on ciliary body, so we should prescribe beta-2 blocker for treatment of glaucoma, but we did give bitoxolol. Now, very good question. Now, beta-2 receptor in the eye is present in ciliary body, and what does it do? Beta-2 decreases the aqueous humor production. It decreases, sorry, the action of beta-2 is to increase aqueous humor production. Clear? This is a normal thing. And you know that beta-2 belongs to GS coupled receptor. It increases cyclic EMP, and that will contribute to increase in aqueous humor production. Suppose I block this beta-2, what happens? There is decrease in cyclic EMP in ciliary body, and that will lead to decrease in aqueous humor production. Clear? So that is why we use beta blockers for glaucoma. We use beta blockers for glaucoma. Yes, sir. We understood, sir. But what is beta blocker? There are 2 types of beta blockers. You can block beta-1 or you can block beta-2. So if you block beta-1, they are called beta-1 selective, or what we call it as cardioselective. Now, what do you mean by a selective? First, understand the term. What do you mean by selective? The meaning of selective means it will block beta-1 also, but it is more blocker of beta-1 and less blocker of beta-2. So it has an action of beta-1 blockade. That doesn't mean that it doesn't block beta-2 at all. Please understand, selective means it will block both, but more blockade is for beta-1. That's the meaning of cardioselective. So the bitoxolol is cardioselective, and if I use an eye drop, and you know that in the eye, the majority of receptor is beta-2. If the majority of receptor is beta-2, where does it work? It will work on beta-2 and block it. That's why we prefer that. Suppose the same question is asked in your exam. Suppose the patient is having glaucoma and the patient is having asthma. Then can I use this drug? Can I use this drug? Bitoxolol? Yes, bitoxolol is safe. We can use it. But can I use timolol? Now when I use timolol is non-selective beta blocker. It blocks beta-1 and beta-2 equally. It's equally a blocker of beta-1 and beta-2. But The thing is, it will also go to the bronchus and it can cause bronchoconstriction. So more affinity to the bronchus also. You may ask a question, sir, will the drug from the eye drop also go into the system? Yes, it will also travel. So if it is non-selective, the problem is it can go and act everywhere. And that's why in a patient with glaucoma and asthma, the preferred one is bitoxolol and the least preferred one is timolol because it blocks the beta 2 and then cause bronchoconstriction. Selectivity means lesser binding to beta 2. Yes. Yes, guys, any queries? There are 32 people. Any queries? Okay. So if there are no queries, let me go for the next question. Sir, my query is regarding route of drug administration. Route of drug administration. Route of administering a drug. So my question is, sir, sublingual route is enteric or parenteral? So actually what happens is, certain books give this as enteral route. But literally speaking, sublingual is parenteral. Certain books give under enteral, oral, rectal, and sublingual. Right. But oral and subrectal, they have first pass metabolism. These routes have first pass metabolism. The drug has to enter the liver and undergo metabolism for the first time. But sublingual doesn't have that. That's why some book give this as parenteral also. This route can be considered parenteral route. Beyond this enterum, there is oral and rectal, and that's why it can be considered as parenteral route. Right? Sometimes when you cannot give oral or rectal, this is the route. So many students ask me this question also. Sir, what is the difference between intraosseous and intraarticular? What is the difference between intraosseous and intraarticular? What is the difference? Very much important. Suppose this is a bone. This is a bone and this is a joint. You know the junction between two bones is joint. What is intraosseous? Intraosseous is nothing but giving it into the bone marrow. It is similar to an intravenous line. When you don't get an IV line, the next thing we attempt is intraosseous. Intraarticular is into the joint space. Now, intraarticular is a local route. What do you mean by local route? If I give a drug there, the drug stays there for a longer time. So very less drug moves into the body. Intraosseous is systemic route. What is the meaning of systemic route? It doesn't stay there. From there, it will go everywhere in the body. That's the meaning of systemic. Now, the question in the future exams to come is, what are the sites where we give intraosseous? What are the sites we give intraosseous emergency route? One is head of humerus. Head of humerus. Second one is lower end of femur. And then upper end of tibia. Sorry, upper end of tibia. And also sometimes in children they use medial malleolus. So these are the ways where we find intraosseous. So that is called intraosseous route. Yes. Okay. Hope you understood the differences, intraosseous and sublingual. In certain books, it's also given as parenteral. Now, please understand the local and systemic. Local means the drug work locally, doesn't go everywhere in the body. Systemic means, suppose I take orally, the drug goes everywhere in the body. Now, can you tell me other local routes? The other local routes are intraarterial, and into the spinal cord is called intrathecal. And the topical applications like your eye ointments, skin creams, all this come under this. Okay. Yes. Moving on to the next question. Sir, as both adrenergic and cholinergic drug can stimulate CNS activity, so can cholinergic drug be used for narcolepsy in place of adrenergic drug? Now, what is the difference between a parasympathetic system and a sympathetic system in CNS, particularly in CNS? Now, a parasympathetic system will make the person relaxed. It increases memory. So, relaxation, memory. But sympathetic is the one which increases attention. So, person will be attentive, more attentive. It's like, sympathetic means adrenaline, fight, fright, and flight hormone. That means attentive, he will be more attentive. Then, if you also increase this, patient will have anxiety. So that means sympathetic means person, if you see these actions, he will not sleep. He will be attentive. So that's why the sympathetic system we utilize to treat narcolepsy conditions. So where the patient is having is narcolepsy, daytime sleepiness, where we want a person to get up and stimulate. Now, why not parasympathetic? Parasympathetic means relax, it's not attention, memory impairment. So we use that in treating a disease where the memory is impaired, that is Alzheimer's disease. So can you tell me the drugs used for Alzheimer's disease? They are nothing but rivastigmine, then donepezil, then galantamine. So these are the drugs. Narcolepsy, what we use is a drug by the name modafinil that can be used. One more drug which is related to histamine is pitolisant. So pitolisant is considered a H3 inverse agonist. And modafinil is sympathetic. So that is why histamine is also required for our active brain. So if you block histamine, there will be sedation. That's the point. Now, sir, will parasympathetic doesn't cause any hyperactivity CNS? Yes. When you give this at high dose, the high dose can activate the brain. That can end up with seizures. So high dose can also excite the CNS. So they can excite, they can relax both, but that is seen with higher doses only, not with normal doses. So the normal thing, this is why we use sympathetic system drugs for narcolepsy and parasympathetic drugs for management of memory impairment, that is in Alzheimer's disease. I hope you got this point. Yes. So moving on to the next important aspect. Next question. Is favipiravir advisable in COVID patients? Sorry. Now, what are the updates? COVID updates. Is there any new drug coming to COVID-19? So COVID-19, is there any new drug? So there were drugs called remdesivir and a drug called favipiravir. Now, actually, these drugs were approved for Ebola. They were not approved for COVID-19. They were there from so many years for Ebola. So, because of an emergency like pandemic, we had to approve them. So, remdesivir was IV and favipiravir was oral. Both of them started inhibiting RNA-dependent RNA polymerase in the virus. So this was the mechanism of action. So is favipiravir effective so much? No, that didn't work much. So remdesivir was used, but even the efficacy was not that, and it didn't decrease mortality in COVID-19. So the one which decreased mortality in COVID-19 was, can you tell me which drug reduced the mortality in COVID-19? Anybody? What drugs reduce the mortality in COVID-19? They are nothing but the steroids. So steroids decrease the mortality in COVID-19. Clear? Then do we have any other drug for that? There was a drug to prevent cytokine storm, and that is called tocilizumab. So tocilizumab is an interleukin 6 antagonist that was used. Then what is that cocktail regimen, sir? Cocktail regimen is a combination of two drugs. So for example, a combination of casirivimab plus imdevimab. So this was a cocktail regimen, and it was used in milder cases. A single dose would suffice. Why? Because this combination used to target, suppose this is the virus, they used to go and block the spike protein. So if you block the spike protein, it can't infect the newer cells. That is why these cocktail regimens were used, and they were very costly for the patient to take up. Now one more regimen that is important is bamlanivimab plus etesevimab. So they are also a cocktail regimen that is used. Now what about the new drug, a molnupiravir, which made sound during second wave? Does it have anything? Molnupiravir, it causes mutations in viral mRNA. So viral mRNA, it used to cause mutations, and that will cause inhibition of viral replication. This was the mechanism proposed for that. Now, was it particularly developed for COVID-19? No. It was a very old drug for the influenza virus, but we came up with this. The problem is mutation. If it can induce mutation in viral mRNA, why not in ours? So that's why in pregnancy it was not used. It was contraindicated, and those who are planning for pregnancy after 3 to 6 months, they were not advised this. So these are the updates what we have for COVID-19. Apart from that, no new drug, no company will develop new drug for this, because after 1 or 2 years, if the drug develops resistance, and the pharma company doesn't want to take the burden of that. Right. So that was about that question. Now moving on to the next. Sir, could you explain how we should shift patient with shift between antipsychotics if a patient develops extrapyramidal symptoms from them? I watched the video, but I could not understand that. If a patient develops EPS, then shift to atypical antipsychotics is what you said. Now, whenever we use typical antipsychotics, now what do? The meaning is typical. They block D2 receptor. Now, when you block D2 receptor, particularly in the brain, it is known to increase prolactin. Not only that, it can cause extrapyramidal symptoms. What are the extrapyramidal symptoms? Number one, acute dystonia, Parkinson's disease. Third, neural malignant syndrome. And fourth, tardive dyskinesia, cathesia, and perioral tremors. So when the patient develops extrapyramidal symptoms, so you have treatment for that. Not only you treat this EPS, the next step should be to shift the patient to atypical antipsychotics. What is the advantage of atypical antipsychotics? What is the advantage of atypical antipsychotics? The advantage is the atypical antipsychotics, they block 5HT2 receptor. Do they block T2? Yes, very, very less. So there is less chance of extrapyramidal symptom. So shift the patient to atypical antipsychotics like this thing. You have aripiprazole, acinipine, quetiapine, those things can be added. So that is one advantage. And the atypical antipsychotics, they don't block alpha receptor, muscarinic receptor, and histamine receptor. This adverse effect is also not seen. The third important advantage of atypical antipsychotics over typical is they can be used to treat both positive and negative symptoms schizophrenia. But in case of typical, you can use it to treat positive symptoms schizophrenia. and these can also be used for resistant cases. The only drawback of atypical ones are they cause metabolic syndrome. That's the only drawback. So that's the reason why we shift. Okay, so let me check any other queries. Rocky, if you have done LMRP once, it's okay. You can do it now. That is also good. You can go with that LMRP also, no problem. Yes. So moving on to the next question. Sir, in pharmacokinetics video, you said that absorption is inversely proportional to first pass metabolism. How can it be? Now in pharmacokinetics, I told you it is a bioavailability which is important, bioavailability. So bioavailability is the one which depends on absorption. If absorption is more, that means bioavailability is also more. This is directly proportional. And second point is bioavailability is inversely proportional to first pass metabolism. So if the drug is metabolized in the liver for the first time more, the drug available is less. So this is what happens with, for example, nitrates, isosorbate dinitrate. It has high first pass metabolism. So what is the bioavailability? Decreases. So this is what I told you. Okay. This is the relationship. Okay. Then let's move on to the next question. So there is a pharmacokinetic question. Let me brief that pharmacokinetic question. So the question is like this. Verapamil was given. Verapamil was given as an oral tablet. And it was given 80 milligram. The dose was 80 milligram. And there was 95% absorption of that. 95% of absorption of that. Then, and the person weight was 70 kg. However, because of extensive biotransformation during its first pass, the bioavailability they have given is 0.25, that is 25%, and they have given liver blood flow in the liver. So liver blood flow is around 1500 ml per minute. Now what they asked is, what is the hepatic clearance of the drug verapamil? Hepatic clearance of drug verapamil. Now what is the formula for hepatic clearance of any drug, not only verapamil, any drug? You have to calculate this hepatic clearance. So hepatic clearance is given by hepatic blood flow, that is nothing but the liver blood flow into hepatic extraction ratio. What is that? HER, hepatic extraction ratio. That means how much is biotransformed. That is the HER ratio. Now this HER can also be given by bioavailability. That is F is equal to F into 1 minus hepatic extraction ratio. This is also a formula. But if you go with the formula, the calculation part becomes a bit tougher. So what I suggest you is, let us take this as the intestine, right? And this is the liver, right? So the drug has to go to the liver. From there it has to come here. So how much was given? 80 milligram. So how much came? 0.95% was absorbed. So they have given 95% absorption. So 95% means 0.95. How much is the bioavailability? 0.25. That means how much is lost during the transit is nothing but 0.95 minus 0.25. That is around 0.7. So 0.7 is the hepatic extraction ratio. That much percentage of drug is taken up. If you remember, verapamil is a drug which has high first pass metabolism. That is the point. So if I replace that, hepatic blood flow is 1500, hepatic extraction ratio is 0.7. If you multiply that, it will be around 5, 7 5s are 3. So it will be around 1050 ml per minute. So it will be around 1050 ml per minute. So this is what we get from the calculation. So here please understand how to calculate this. That's it. How the calculation is done. So number one, you need to understand hepatic clearance is given by the formula hepatic blood flow into hepatic extraction ratio. Now only if they give fraction of absorption, then we use this formula. If they are given 95% absorbed, then we use this F value. Then we multiply into 1 minus HR. Suppose if they don't give this F value, then F is equal to 1 minus hepatic extraction ratio. So if they don't give percentage absorption like 0.95 or something like that, then you can directly do that 1 minus HCR. Right? That can be done. Suppose, sir, if I take like bioavailability is 0.25, 1 minus hepatic extraction ratio, I don't know, sir. Then how do you calculate this in this? So then hepatic extraction ratio is equal to 1 minus 0.25. Right? 1 minus 0.25, that will be around 0.75. Hepatic extraction will be 0.75. Otherwise, if you want an exact value, it will be around 0.7 because they are given the fraction of absorb. Right guys, I repeat again, F is equal to 1 minus hepatic extraction ratio. F capital letter means it's a bioavailability, and if I substitute that, it will be 0.25 is equal to 1 minus hepatic extraction ratio. So if I shift hepatic extraction ratio this side, this will become 1 minus 0.25. That will be around 0.75. So if I multiply that with 1500 into 0.75, around 1125 ml per minute. Now why the values differ? Because I have not taken the absorption part here. That's why. Please remember the calculation part is very, very important. Clear? Yeah. So that point is to learn. Now why some drugs act as agonist and antagonist under different circumstances? Now, any drug which acts as agonist or antagonist, there is something called two-state receptor model. Receptor active, receptor inactive. There are two states of receptor. Usually, when no drug is binding, they are in equilibrium. So, a receptor without any stimulation, they are in equilibrium. Active means it will produce a response. Inactive means it will produce the opposite response. Now, an agonist binds more to this. So that it will increase the state towards this one. Antagonist will bind to both and it can make both the states available. And inverse agonist bind here. So this is a two-state receptor theory that will explain this. Why certain drugs act as agonist, antagonist, and inverse agonist. This is a theory proposed. So why is ethambutol static while other antitubercular drugs are cidal if they all inhibit cell wall synthesis? Number one, remember cell wall synthesis inhibitors. Cell wall synthesis inhibitors. So there is a general term that all these are cidal drugs. That's a general notion we tell in the classes. But there is some exception also. If you take a case of cycloserine, cycloserine is a 2B drug and it is a tuberculostatic. It's not cidal even though it inhibits cell wall. Ethambutol also will affect a cell wall synthesis, but it is also static drug. Now not only the static or cidal drug depends on these factors, there is one more thing called minimum bactericidal concentration, and MIC, minimum inhibitory concentration. These two parameters also play a role to determine a drug is bactericidal or bacteriostatic. So that will be in detail for you, not required. So remember, almost all cell wall synthesis inhibitors are cidal. There are two exceptions: cycloserine, which is a tuberculostatic; ethambutol, it's a static drug. Oh yeah, it's also a tuberculostatic drug. Yes, very good question. Yes, any other doubts, guys? Yeah, so I'll take up next question. Now the question is, sir, prazosin is a vasodilator or artery dilator? Now, what are drugs which are artery dilators? Artery dilator, then venodilator, and both, which can dilate both. Now, the drug which can dilate both, that is called sodium nitroprusside. Sodium nitroprusside. Then AC inhibitor, ARBs. Then the alpha blockers like prazosin. So they can dilate both equally. They can dilate both of them equally. Venodilator meaning, please understand that they can also dilate the artery, but mainly they dilate vein. That's the meaning. I'll repeat again. A venodilator drug means it dilates vein more than arteries. The main venodilator are nitrates. And rest all the other drugs, they are predominantly artery dilator. So better term, what I can tell you is predominant artery dilator. So predominant means they can also dilate vein, but predominantly artery. This is predominant venodilator, and both equally is these drugs. So the artery dilators are the rest of the things. What they give in the exam, hydrolysin, CCBs. So all other drugs comes under this predominant artery dilators. Okay, so prazosin is both. Okay, so moving on to the next question. Okay, sir, which of the following statements about clinical trial is true? Post-marketing surveillance is done in phase 4. Yes, post-marketing surveillance is done in phase 4. So in phase 4 post-marketing surveillance, we find out all this rare adverse effect, drug interaction, and we check the drug in special population like pregnant, lactating, and in children's. Unit of study in phase 1 is patients. Now that's a false statement, because unit of study in phase 1 is human healthy volunteers. Mainly phase 1 means human healthy volunteers, and the major aim is to check for safety and also to check for the maximum tolerated dose and then pharmacokinetics. This is the order. Very rarely we include patients in phase 1. Safety is evaluated in phase 2. Yes, that is also a true statement, because every phases we evaluate safety, pharmacokinetics. But if they ask you what is the major aim of phase 1, it is safety. So all the phases will be evaluating pharmacokinetic safety. Right, randomized control trial in patients is done in phase 3. Yes, that is also true. Randomized control trials, we do it in phase 2, we do it in phase 3 also. The same randomized control trial, if you do it in phase 4, we also call it as some epidemiological study, or we call it as phase 5 trial. That is also done. Right. Okay, so let me check your queries, guys. No other queries? Come on. Waiting for our questions. Okay, so I was not able to see your questions. Okay, so I'm getting your... Okay, guys, so I got your question now. Sorry, I was not getting this live chats. Let me check your... Okay, let me answer your Kunal. So, sir, please tell me non-competitive antagonist. Now, there is a concept called competitive antagonism and non-competitive antagonism. Non-competitive. Now, simply remember, competitive means if this is a receptor, the agonist and the antagonist, both of them bind to the same site. So competition means same site. The non-competitive means if this is a receptor, it has one more site called allosteric site. So this site the antagonist bind, and here the agonist binds. So this is called non-competitive. Simply, competition means same site, non-competitive means different site. Chinmay, sir, why aspirin is not given in primary prevention of MI? See, primary prevention of MI, only if there is a high risk patients, then we give aspirin. Without any high risk, we don't use, because aspirin, number one, gastritis, number two, bleeding risk. That's why if they are high risk patients who have a family history of hyperlipidemia, atherosclerotic cardiovascular diseases, then we can start with that. Otherwise, majority we use for secondary prevention. Yes, many have answered. Why lignocaine is used with used in arrhythmias? Now, lignocaine belongs to class 1B antiarrhythmic. Class 1B antiarrhythmic. Now, it is mainly used for ventricular tachycardia. So, ventricular arrhythmias. Now, what happens is whenever there is an action potential, the sodium enters. This is the point where sodium enters. Right. So arrhythmia means the cardiac tissue is firing. It is firing a lot. Now, if I allow sodium to enter faster, the arrhythmias will occur, the contraction will increase, the impulse will increase. So what the scientists thought, let us block this sodium channel. Now, lignocaine blocks the sodium channel briefly, that is up to less than 1 second. Now that sodium channels are called use-dependent sodium channels. What are they called? Use-dependent sodium channels. Now these use-dependent channels are overactive in ischemic tissues. Ischemic tissues means in MI. So that is why it can prevent this rapid entry of sodium, and thereby it can prevent arrhythmias. That is about lignocaine. Yes, Ramesh Pandey, I told you sublingual. It is parenteral. According to few books, yes, it is also parenteral. Faim Ahmad, how do you manage enterine poisoning? Enterine poisoning is called organochlorine. It is not organophosphate, it is called organochlorine. For example, the DDT, which you used to kill the ants and all. Now for this, there is no treatment. So it is going to cause seizures. It's a neurotoxic. So only symptomatic treatment. Suppose a patient develops seizures, we use anti-epileptic drugs. Manage the patient symptomatically. There is no particular antidote for that. For example, organophosphate, we have a specific antidote. For this, there is nothing. Okay. No. Which of the following does not appear in official definition of Vishek? Which of the following official definition? Treatment, cure, mitigation. Mitigation doesn't come here. Treatment, cure, and prevention will come. Okay, Himanshu Taylor, how to calculate therapeutic index? So therapeutic index is given by the formula LD50 divided by ED50. So they would have given what is the dose, lethal dose 50 and divided by effective dose 50. For example, if they are given lethal dose 50 as 4 milligram and this is 1 milligram, so therapeutic index will be 4. That is the formula. So if the drug is having low therapeutic index, then it is less safe. If the drug has high therapeutic index, then it is more safe. Yes. Okay, so if you're first year student, I think you can concentrate on your first year subjects. Then you can come to the second year. That's the main thing you have to concentrate. Tanvir Gupta. Propranolol is the beta blocker. So don't worry about second year now, because in first year what you learn is normal physiology. Once you are thorough with physiology, then you will understand pathology and pharmacology. First you should know what is normal temperature, then you will understand what is fever, then I will tell you what is the treatment for that. Beta blocker and nitrate should not be combined. Why? Who told beta blockers and nitrates should not be combined? Beta blockers and nitrates are combined. Yes, they are combined. Why they are combined? Because when we use nitrates, they cause vasodilation and decreases the blood pressure, and the heart will increase the heart rate. That is called reflex tachycardia. So this will be heart rate is increased. So to avoid that heart rate, if I add beta blocker will suppress the increase in heart rate. So the combination is rational. Beta blocker nitrate combination is rational. It is given. Okay, so any other question? Paxlovid it's still under therapy. Rishabh Bhagat, most of the fluoroquinolone you cannot combine with theophylline and warfarin because they are enzyme inhibitors. Muhammad Arif 58, sorry, why M3 causes gut relaxation? See, now the cyclic AMP is the one which decides all those things. So M3, it is GQ coupled receptor and they can activate IP3DAG. But since it's parasympathetic, the activity is to relax the smooth muscle. But alpha 1 is sympathetic, that is also GQ receptor, but the second messenger will dictate what to do in this tissues. So it will relax it. Now, how volume of distribution and half-life is related? T half is equal to 0.693 into volume of distribution divided by clearance. So this is the formula how half-life and volume of distributions are related. Right? Akash Hiramat, which diuretic is used in diabetes insipidus? The diuretic that is used in diabetes insipidus is thiazides. So thiazides can be used in both. Thiazides can be used in both central and peripheral diabetes insipidus. Right. Now, if they ask in the exam, what is the drug of choice for lithium-induced diabetes insipidus? Lithium-induced diabetes insipidus. Then another diuretic that is used is amiloride. So there are two examples for your question. Thiazides and amiloride, they are diuretics which can be used. Okay. Yes, so sorry, I couldn't get to your questions now. That's why yes. So until you ask me those queries, let me check for other questions here. Okay, so one more query by the Fahima Ahmad is, sir, what about in carbonate poisoning? OP poisoning, you told we can use atropine and oximes. But in carbonate poisoning, we cannot use oxime. So what to do? In carbon poisoning, only thing is drug of choice atropine. And along with that, we put the patient on ventilator, and the enzyme should get reactivated on its own. It takes time. So until that patient will be in ICU. Okay, so any other queries? Let me check. I think a bit delay here. Okay, Meghanathan, let me explain the doses. So dopamine, I have to tell you, dopamine doses. I'll just tell you. So dopamine levels, please understand, if you are using less than 1 to 2 microgram per kg per minute, then it acts on D1. And D1, it causes renal vasodilation and it can increase renal blood flow. More than 2 to 10, it acts on beta 1, increase the heart rate, force of contraction and conduction. More than 10, it acts on alpha 1 and can increase the blood pressure. So this is the actions what we see with these things. Now the doses used for cardiogenic shock with oliguria, this is 1 to 10. Why? Because this range of 1 to 10, it can take care of both the heart and kidney. So it is used for cardiogenic shock with oliguria. So we can use it. Yes. Yes, DHPs where you cannot combine. See, non-DHPs is the main thing they ask you about. Don't worry about DHPs. Non-DHPs like verapamil. Verapamil should not be combined with beta blocker. Why? Because it also decreases heart rate. It also decreases conduction. Even beta blocker decreases heart rate. Even this one decreases conduction. So these should not be combined. Now, verapamil, that is not ibuprofen, should not be combined with DHPs like amlodipine. The reason why the amlodipine should not be combined, because both of them have same mechanisms. So in pharmacology, if the drugs have same mechanisms, we don't combine. The reason is their efficacy, the actions will add up, but not only that, their adverse effect add up. So adverse effect will increase. So the same mechanism of actions we don't combine. Azmat study family. Best book for pharmacology for what? We have standard textbooks like Katzung is better. Katzung textbook can be used. Imanshu, I think we don't have time to explain 4 drugs here. Yes. So some of the questions, updates I have to give you in a brief manner. Semaglutide, the specialty is, I told you in all the pharmacology classes, anything getting with tide, it's a peptide, you cannot give that orally because it's a protein. Recently, this is also available as oral drug. So semaglutide is a GLP-1 agonist which is available as an oral drug. Most of the students ask me, sir, what is the drug of choice for childhood absence seizure? Now, if they have not mentioned the age and if they give you an age of child, then the drug of choice nowadays is ethosuximide. So ethosuximide, if they have not told you as child or something like that, then it is valproate. Now therapeutic drug monitoring of lithium, for maintenance or prophylaxis, we maintain between 0.6 to 1.0 milliequivalent per liter. Then for mania, acute mania, it is 1.0 to 1.5. Then toxicity, we call it as more than 1.5. Admission to the hospital is more than 2, and more than 4, it requires dialysis as per Harrison. Yes, Now, drug of choice for pseudomembranous colitis is also operated, that is, oral fidaxomicin can be used. If that is not in the option, the next option will be oral vancomycin. Then what is the drug of choice for mania in pregnancy? It is the atypical antipsychotics. So we cannot give lithium, we cannot give valproate, carbamazepine because they are teratogenic. Yes. So Karishma Sinha, she has asked a query. Let me answer that. Just a minute. Yes. Acute CSF. Now, acute heart failure means acute CHF means the heart is not able to pump. So if the heart is not able to pump, that means the beta 1 is not working properly. So beta 1 is the one which increases the force of contraction, and in acute CHF already there is decrease in force of contraction. If I use beta blocker, they decrease the force of contraction and they will worsen the CHF more. That's the reason. What happens in chronic CHF? Chronic CHF, there will be increase in aldosterone, and that will cause the ventricular remodeling, and that will cause the permanent heart failure, and death rate will increase, mortality. So how do we get aldosterone? It is by the beta 1 action on renin and renin angiotensin aldosterone system. So this beta blockers will block this and the aldosterone level decreases. That is one reason why we use it in chronic CHF. But while using in chronic CHF also beta blocker, there is a risk of again a problem. Heart will pump very slowly. So that's why when you are starting beta blocker, you have to start with very low dose. Then you have to gradually increase if the patient tolerates. How do you know whether the patient tolerates or not? If he develops edema, if he develops weight gain, that means he is not tolerating beta blockers. Then you have to reduce the dose or stop it. That's what we can do. Okay, so drug of choice for insomnia plus anxiety. If the patient is having insomnia plus anxiety, then better to go with benzodiazepines. You cannot use SSRIs because SSRIs itself cause insomnia. So that can be done. And one more option is you can use buspirone, but buspirone doesn't cause any sedation. It's only an anti-anxiety drug. Acute attack of acute congestive glaucoma is astazolamide. If they give mannitol and astazolamide, it is astazolamide. A very good question, Nitesh Singhal. Though parasympathetic increases peristaltic movement of GIT and bladder, but when we have fear or excitement, whenever sympathetic system is activated, we have urge to defecate or pass urine. See, that's what happens. See, this defecation and urination, it's also under our control. Autonomic nervous system is not under control. So suppose suddenly I want to urinate, I have a control, voluntary control. So the bladder and intestine is not only controlled by ANS, it is also controlled voluntarily. Suppose I am anxious, I am feared, then the voluntary control is lost. That's why there will be defecation urination. Okay, so that's the reason. Okay guys, so that's it for now, and thank you for your questions. Okay, so thank you. Take care, and we'll be meet up in the next doubt session. Any other doubt, I'll be happy to take up. And I hope I solved your queries. Yes, Nitesh, I think you got that concept. There is something called voluntary. Okay, so good night, take care. Thank you all.